Hello, I'm Adrian Richards and I'm a plastic surgeon. Today I'm going to be talking a little bit about inverted nipple correction. Now, this is something I'm very interested in and quite passionate about because I've seen many patients with inverted nipples, and it really can affect people. They don't like them. It makes it difficult wearing clothes. Often the inversion is difficult to conceal through thin clothing, and it makes some sort of intimate relations difficult for some people. So, inverted nipples are common and they cause distress, and the most important thing is they're easily corrected under local anaesthetic. Okay, now there are three grades of inverted nipple. Grade 1 are nipples which are inverted but do evert on the stimuli and stay everted for a period of time. Grade 2 inverted nipples are inverted, do evert but invert spontaneously and don't stay everted. Grade 3 are inverted and never become everted. Okay, now different procedure really for each type of inversion. Grade 1, these are the ones that come out and stay out for a period of time, are often best treated by a suction device known as a nipplet. So Nipplte, which is a suction device used normally at night, which tends to slightly stretch the milk ducts which are causing the inversion, and often is very effective for a grade 1 inversion. So I would normally suggest that anyone with grade 1 inversion certainly tries the nipplet suction device. Okay, why do people get inverted nipples? It's a shortening of the milk ducts. So the milk ducts travel from the milk glands to the nipple, and in some people, as the breast grows, the ducts do not grow sufficiently and act as a tether, pulling the nipple in. Okay, so the nipple that wants to come out can't come out because it's tethered. So for grade 2 nipples, there are different approaches. Again, operations for under local anaesthetic typically takes 10 minutes per nipple, and the options are either to stretch the nipples but keeping them intact, stretch the ducts, the milk ducts, but keeping them intact, or divide them. Okay, so on grade 3, these are nipples which are inverted and never come out. The only real option is to divide the milk ducts, because the milk ducts are so strong and tethered, you won't be able to tease them out to get an adequate increase in length. Okay, so grade 3, division of the ducts. The only problem with division of the ducts is you won't be able to breastfeed after the ducts have been divided. Grade 2, you need to make a decision about how important breastfeeding is for you. If breastfeeding isn't of crucial importance, if the surgeon divides the ducts, that's the most sure way of correcting the nipple inversion. But if breastfeeding is very important to you, you need to discuss possible operations to lengthen the length of the ducts by teasing the ducts out. Okay, so grade 1, think of the nipplet. Grade 2, options are either duct teasing out, duct lengthening, or duct division. Grade 3 is a really duct division. Okay, how's the surgery performed? Well, it's under local anaesthetic. I do it as a walk-in, walk-out procedure, which typically takes about 30 minutes in total. The nipple area is cleaned, local anaesthetic infiltrated into the nipple, and after that it really shouldn't hurt at all. And a very small incision is made just at the base of the nipple. The ducts are either divided and teased out through a very small incision, and then an absorbable internal stitch is used to hold the base of the nipple together to stop the inversion. And then a light dressing of brown tape is put on, which is changed after a week. And thereafter you don't need any more dressings. So it's a very successful operation, minimal scarring, really quite minimal downtime. If the ducts are divided, the risk of recurrence of the inversion is really very low. And nipple sensation, because nipple sensation comes via the skin of the nipple, which is not affected. Nipple sensation in over 90% of cases is not affected at all. So again, if you have got inverted nipples, very common, 1 in 10% of the population do have some inversion. If you suddenly develop inversion when you haven't had inversion before, you need to go to a GP or a breast specialist just to make sure that there's no underlying abnormality of the breast, because cysts or occasionally breast cancers can cause sudden inversion of the nipple, so that needs to be checked out. If it's long-standing inversion, though, ever since your breasts have developed, there is a technique to correct it under local anaesthetic, but you need to think carefully about breastfeeding and have a full discussion with your surgeon about the best approach for you. I have talked to patients who've had inverted nipple corrections and other surgeons about their approach to inverted nipples in our podcast, if you would like to listen to those. If you have any questions about inverted nipples and how they're best treated, please feel free to either email us at Aurora Clinics or ring us or email any form of contact, and we're more than happy to answer your questions. So I hope that's answered some of your queries. Thank you for watching.